Ladies and gentlemen, thank you very much for inviting me to participate in this event. I look forward to talking to you about what's needed for Western Balkan countries to close the gap in access compared to EU. So I don't want to start the presentation pessimistically, quite the opposite in fact. But I think it's incredibly important for us to realize the fact that due to the fact that Western Balkan countries are far less wealthy than they are than the EU, and then consequently they spend less on health and less on medicines, much significantly less, that it's imperative that if Western Balkans wants to catch up, that health and access to medicines are prioritized in public and political agendas in the countries. And this translates into financing, so more funds, right? A greater share of wealth spent on health. That health systems are much more efficient than they are now. For instance, the OECD projects that up to 20% of all health expenditure, even in the developed countries, is wasted. And we often hear that expenditure on medicines is a problem. I think this is dangerous because it ignores other larger inefficiencies in health expenditure, such as, for instance, hospitals, primary care, lack of integration of care, no focus on outcomes, and similar. And then, last but not least, of course, expenditure on medicines. So what we spend on drugs needs to be rational, and we need to have decent, advanced HTA systems in place, and need to prescribe medicines rationally. So this is what countries should focus on, and I'll expand on that in the rest of my presentation. But I think equally important, we have to invest additional efforts to develop partner relationships with the pharmaceutical industry, because it's not rational to expect that we can ever close the gap if Western Balkan countries pay the same prices for medicines as their much richer counterparts in the West. So we need to talk about this with the industry and come to some common ground. Right? So I'll structure the presentation so that I'll discuss common issues in Western Balkans countries, and then best practice in neighboring EU states. And in doing so, we'll focus on medicines financing, how we develop benefit packages, so lists of reimbursed drugs, company submissions, what we request from companies as evidence, our assessment and appraisal processes, how we reach decisions on reimbursement, and what happens to drugs post-listed. So let's start with financing. Right? Some of the common financing issues in Western Balkans are poor budgeting practice. We have Ministry of Finance dominated top-down budgets that take little regard of needs analysis, low health insurance fund financial autonomy, often coupled with misappropriation of healthcare funds. And I'm referring here specifically to the example of VAT, whereby we collect health insurance contributions from the population in the health insurance funds, and then when health insurance funds pay for medicines, they need to pay VAT on them, sometimes at high rates, and then channel this money back to the Ministry of Finance. Our expenditure forecasts are often simplistic and inaccurate. We particularly pay very little attention to horizon scanning. So we're not sure what's coming in the future and how to accordingly plan for it. And the options for redistribution between healthcare sub-budgets are often very limited, if existing at all. I'll give you an example. If tomorrow we were offered a medicine that would cut hospital expenditures by, let's say, 5%, we wouldn't be able to rebalance these budgets, because budgets function as separate silos. So all of this, I think, often leads to unrealistic budgets where not enough funds are budgeted to support current benefit packages, let alone needs or wishes. So we have limited fiscal space for innovative drugs. This, of course, leads to access issues, delays in access and poor access to innovation, sometimes to arrears for wholesalers, drug shortages, severe rationing, and generally poor predictability of funds in future years, so that this really creates difficulties for reimbursement decision making. Equally so, I think another large problem is that domestic generic companies are often seen as generating employment, while innovative companies are considered as foreign. So there's poor awareness of health benefits accrued from innovative drugs, which leads to low public prioritization, then underinvestment in medicines generally, sometimes overpayment of generic drugs. So altogether, resulting in narrow fiscal space for innovative medicines. Some of the steps forward that we can see in the EU, our neighboring EU countries, are efforts to improve expenditure analysis and projections, so that we're better aware of where we stand and how much we can afford. Global pharmaceutical budgets, discounts in countries such as Slovenia and Hungary, centralized hospital purchasing in a number of countries. Croatia is a good example where it has created massive savings. Dedicated funds for innovative drugs, which make sure that some money is put aside specifically for improving access to innovation. Or, for instance, in Slovenia, they don't have an expensive drugs fund, but the health insurance fund will have additional payments to hospitals for expensive drugs. So this makes sure that these drugs are accessible and that there's equity in the country and that they're affordable to all hospitals. Well, in the definition of pharmaceutical benefit packages, I'd say that one of the main issues is there's few strategic documents that are guiding policy and practice, and even if these exist, they're often poorly implemented. Other issues include brand name-based lists, which support marketing competition between generics instead of price competition, which would lead to savings, and then these savings could be used to improve access to innovative drugs. Issues with therapeutic guidelines, so that when pharmaceutical benefit packages are blurred, we're not 100% sure on what should be provided and at what time. Inequities such as access to non-reimbursed medicines through hospital budgets or through separate Ministry of Health budgets, and very often these don't entail standard HTA processes that guide general reimbursement. And then, last but not least, infrequent updating of lists, often due to merely low administrative efficiency. Another very important, I think, concept that we have to understand is that the fact that a drug is listed on a positive list doesn't necessarily mean that this drug is accessible to the population. And these are a couple of figures from a research I did several years ago, where in 2017 I analyzed 46 IMNs within oncology, and we looked at how many of these drugs were reimbursed in Slovenia, Croatia, Bulgaria, Romania, and Serbia, and what the actual expenditure on these 46 drugs was. So, as an example, Serbia had half of what Slovenia reimbursed, so 50%, but its expenditure on these 21 products was 12 times smaller, almost 12 times smaller than what Slovenia spent per capita. Right? So as far as steps forward go, I'd say the first is we have to make sure that reimbursed medicines are actually accessible and used in the health system. That savings generated through reference pricing, and all of our countries engage in external and very often internal reference pricing also. That these savings are used to improve access to innovation. We need to make sure that prescribing restrictions promote rational use of medicines, so that they're evidence-based and smart. I'm a big advocate of one centralized pharmaceutical benefit package that guarantees that everyone in the population has equal access. And then I think also the Slovenian voluntary health insurance coverage of co-payments model is something that a lot of countries could learn from to make sure that these benefit packages are actually accessible to the population, and that user charges are not hindering access. With regards to dossier submissions, I think a lot of countries in Western Balkans request complex modeling, cost-utility analysis, where there is low local capacity to produce it, and then even worse, where recipients can't really scrutinize it. They don't have the necessary knowledge and experience. I think we may be over-relying on imported HTA assessment. To give you an example, the fact that NICE concluded that a drug is cost-effective in England, there is little relevance for any of our countries, because we don't know at which prices it was deemed cost-effective due to the financial discount that NICE arranged with the producer. And then, generally low availability and quality of epidemiologic and cost data, which is prohibiting development of health economic analysis in practice. Steps forward, I think perhaps modest, but Croatia has a decade ago started publishing most solutions on the internet, so has increased the transparency of this process. Croatia, Slovenia have invested a lot of effort in developing detailed instructions for reimbursement dossiers. I think Hungary has a pharmacoeconomic guideline which is state of the art and in all of Europe, and then we see a lot of effort in collecting and publishing epidemiologic and cost data. In assessment appraisal processes, we have a lot of issues, very few critical appraisal checklists, so unclear assessment methodologies. So it's not perfectly clear and transparent how the process should look like. I think there are issues with appointment of committee members, which is often politically influenced. Committee members often have very little health economic expertise, so it's hard for them to assess requested budget impact analysis and cost effectiveness analysis. Committees have short tenures, they're changed often, so this leads to it's very difficult to develop institutional experience this way. I see few countries seeking expert assistance from the outside, either by individuals or by institutions. I think the Scottish Medicines Consortium is a good example how a small country such as Scotland, to which we can relate to, and the institution which is in charge of HTA there actually draws a lot of expert assistance from the outside, and was thus able to create a European best practice level of how they assess drugs. I think a further issue with committees is that these are often populated by distinguished clinicians, professors, so they can in reality dedicate modest time and attention to assessment because they're more than full-time employed in their hospitals. I think a lot could be done to improve procedures that deal with conflict of interest. Assessment criteria in many countries are nominal, so they're unfit for practical decision making. We don't use consensus building methodologies that would structure these processes. The prioritization between submissions is often undertaken informally or relying on budget impact. And there is no publishing of opinions and grievance redress mechanisms for companies or quality management that we would use to standardize or evaluate opinions and then draw lessons on how to improve practice in the future. In terms of step forward, I think Slovenia has done a fantastic job. For the last couple of years, they're publishing well-argued, detailed opinions, what their Committee for Medicines concludes, and they're openly discussing these with companies. Hungary has a detailed methodological HTA checklist, so the process is standardized. A number of countries are using UNEP HTA. And then I'm not a big fan of the Romanian scorecard. I think there are issues with the criteria there, but I'm a big fan of how they're using it, again, to structure the thought process and make it more transparent. And then in the end, I think Slovenia and Croatia are more and more using expertise from the outside. So, for instance, the Croatian Drug Investment Committee now cooperates with over 40 distinguished experts from the entire healthcare system, and they're actively asked for their opinions. In decision making, so not HTA, in Western Balkans, I see three groups of issues. Well, the first one is ownership of decisions, where it's often not exactly clear who and based on which criteria made a decision whether to reimburse or not. Often it's management boards, or even in some countries the government takes the decision, where it's clear that it doesn't have the competence, the really professional competence to make these decisions. In terms of process, the decision-making process is often closely and informally interlinked with recommendation making, and I think this should be separate. Deadlines are, even if they exist, often not followed in practice, so that decision-making is prolonged. And similar as with assessment and appraisal, it's unclear how prioritization between different products recommended for financing is done. The mandates, methodologies, and criteria for negotiations and management agreements are also often not clear. And then again, I think we could improve procedures that deal with conflict of interest. In terms of accountability, there's no publishing or elaboration of decisions. Medicines either turn up on the reimbursement list or are rejected, but it's unclear why. There's no oversight of negotiations, decision making, and again, no quality management used to standardize or evaluate past decisions. Last but not least, again, grievance redress is in all countries, I think, possible on administrative issues only. So companies cannot seek justice or if discuss if they have different views. Steps forward, I think, include clearly set priorities. The Serbian Ministry of Health has done this for the first time in 2016, and if I'm not mistaken, has continued this practice. Delegating decision-making on some decisions, such as, for instance, reimbursement generics, from management boards to health insurance fund directors. Slovenia and Hungary have published ICER thresholds. These are soft thresholds, but are assisting in decision-making. And then I think the EU countries have, over the last years, invested a lot of effort to better design management agreement negotiation procedures to make sure they're efficient and as transparent as possible. In risk management, I think in Western Balkans we often see poor prescriber monitoring and incentives. So rational prescribing is an issue. Most of the countries have introduced financial management agreements, but some are still lagging behind. Some countries are having issues in management agreement architecture, because of duration or the terms and conditions, and there's very little work being done in terms of outcomes-based management agreements. And I think this is going to be a hot topic in the future for sure, if we want to have efficient expenditure and value for money for what we invest. Unfortunately, also few positive examples from neighboring EU countries. Prescriber monitoring and incentivizing. Croatia could be a good model here. The Health Insurance Fund has been working very proactively on this for years, and then as there's more experience with management agreements, as they were introduced earlier, I think also this has helped in their development and their improvement. Post-listing in Western Balkans, very little, if any, sustained activities to monitor or assess real-world evidence. So we're not sure whether what was promised based on clinical trial data is actually happening in the health systems, and then inadequate use of prescriber guidelines and clinical pathways to make sure that we're getting value for money, and that those people who really need the drugs are the ones who are getting them. Steps forward. Here I also see outcomes-based management agreements as one of the solutions. Romania is planning some work on real-world evidence studies, which should be mandatory. It's not implemented yet, but it's planned for. Bulgaria has also introduced free annual HTA re-evaluations, and then again, countries are investing in developing their monitoring and evaluation of prescribing systems. So to conclude, I think as a way forward, if we want to close the gap as much as we can, we need to work on the efficiency of what we do, quality, accountability, and transparency. And I think the work here starts with budget performance analysis, so that we know how much we're spending and how much we're going to spend in the future, so that we're able to define fiscal space for innovative drugs, how much we plan to spend, how much we can spend. Then, as these funds are limited, even in much wealthier countries, we need to invest more effort into prioritizing, discovering and being clear about what are our greatest needs at the moment. We need to, invest significantly more into developing expertise, skills, and making HTA processes more transparent. And I'm not necessarily here a fan, even though I am a health economist, of complex methodologies. I think I mean, if it's better to have, a less complex or more blunt methodology which we are able to implement to the full extent than it is to have something very developed, very advanced, but that we're not really able to stomach. I think decision making should be devolved to the appropriate level, and we should avoid political interference of any sort. And then, last but not least, we need to invest more effort into developing partnership with the industry, because it takes two to tango. So thanks for your attention, and I'm happy to answer any comments and questions.